Welcome to this video on acute pyelonephritis. This video will cover the definition, pathophysiology, causes, clinical presentation, diagnosis, and treatment of this condition. Acute pyelonephritis is a bacterial infection of the renal pelvis and kidney parenchyma, with an onset typically in less than 2 weeks. It commonly originates from a lower urinary tract infection that ascends to the kidneys. Depending upon the age and overall physical health of the patient, acute cystitis, or a bladder infection, may advance rapidly. The localized bladder infection can spread via the ureters and elicit an inflammatory response. Sexually transmitted infections, such as gonorrhea, chlamydia, and syphilis, and common microorganisms, such as Proteus mirabilis, Group B hemolytic streptococcus, E. coli, Staphylococcus aureus, and Klebsiella are responsible for infection. Infection can come from an internal or external source. For example, translocation of bacteria that live in the colon can transfer to the bladder wall and cause acute cystitis and lead to pyelonephritis. External sources are typically introduced from the urethra. Special populations of patients that have a urostomy, surgical stoma to void through the external bladder wall, perform self-catheterization, or have chronic indwelling urinary catheters are susceptible to recurrent infections. They require potent antibiotics and a much longer course to prevent the development of new microorganisms, antibiotic resistance, or sepsis. This can lead to renal edema and impaired kidney function, and an overwhelming bloodstream infection, known as sepsis, if left untreated. Fatalities due to sepsis, secondary to acute pyelonephritis, have occurred. Causes of acute pyelonephritis often involve an untreated UTI from bacteria introduced through the urethra. Bacteria that originates from an external source can travel through the urinary meatus and advance past the urethra, through the ureters, and cause a kidney infection. Other contributing factors include dehydration. Once dehydration sets in, the body's pH and normal flora are altered. This change in the body's homeostasis makes one susceptible to acute cystitis or acute pyelonephritis. Delayed or incomplete antimicrobial treatment can allow microorganism to replicate and worsen the present infection. Anal sexual activity can introduce bacteria that exist in the colon to cause infection in the genitourinary tract. Spermicides and vaginal-scented suppositories alter the pH and milieu of the vagina and make the vaginal vestibule susceptible to infection. Untreated and chronic hyperglycemia compromises the immune system and makes diabetics prone to genitourinary changes and bladder/kidney infections. Last, improper hygiene can introduce bacteria into the genitourinary system or make one prone to infection. The clinical presentation typically includes costovertebral angle tenderness. During the physical examination, the provider will perform a gentle, direct fist percussion over the lower back to elicit a painful response to confirm the diagnosis of pyelonephritis. Clinical presentation includes fever, chills, body aches, nausea, and vomiting. Patients may also present with blood or white blood cells in the urine, which is noted on the urinalysis report or direct visualization of the specimen. Patients may complain of a sensation of fullness of their bladder due to incomplete bladder emptying or bladder spasms. Inflammation of the bladder due to the inflammatory process causes dysuria or painful voiding. Geriatric patients may show confusion and mental status changes. This can delay much-needed antimicrobial therapy and allow the kidney infection to advance to sepsis, secondary to a kidney infection. Diagnosis involves a thorough history and physical exam. Palpation of the bladder to assess for distension and displacement due to incomplete bladder emptying. Palpation to the flank area to assess for a pain response. Laboratory tests include urinalysis to detect nitrites in the urine that suggest that the microorganism is bacterial in nature. This is useful in ruling out a sexually transmitted infection. Proper treatment is key in eradicating the causative agent. A urine culture is often performed to determine the exact cause of the infection and which antibiotics the antigen is most susceptible to. A complete blood count is useful to determine the severity of the infection and to determine if intravenous antimicrobial therapy should be initiated. Diagnostic imaging, such as a CAT scan or ultrasonography, may also be used. An ultrasound of the bladder can show inflammation and infection of the bladder and kidneys. A CAT scan of the kidney will show acute versus chronic pyelonephritis and identify any renal calculi, masses, or phlegmon that may require surgical intervention along with antimicrobial therapy. Treatment focuses on determining the cause and administering appropriate therapy. This involves rehydrating the patient, typically with oral or intravenous fluids, and prescribing antimicrobial therapy. The preferred route or hydration is oral, unless the patient has persistent nausea with vomiting. Intravenous hydration may be performed with isotonic fluids and/or fluids with additives such as potassium due to electrolyte loss. Hypodermoclesis has been effective in veterinary medicine, and it is gaining popularity amongst those that are poor venous access candidates. The process involves choosing a recommended site to perform interstitial fluid resuscitation. The process is much like intravenous hydration, but a vein is not required for installation of fluids. Commonly, pediatric and geriatric patients benefit from this method of fluid rehydration. The site is marked by soft tissue swelling, and then over the course of hours, the site absorbs the fluid to rehydrate the patient. Surgical intervention may be necessary for underlying issues, like renal obstruction or vesicoureteral reflux. The cause of the infection must be determined and corrected to prevent exacerbation of the illness.
These are the references used for this video.